Hi, everyone, and welcome to an Open Minds webinar sponsored by Nextgen Healthcare on CCBHC capabilities. This is obviously a very popular topic. We had a huge number of people registered, and I assume that we're going to have people coming on within the next few minutes. So we're going to go ahead and get started. Again, I want to thank Nextgen Healthcare for making this webinar possible. I am Sharon Hicks. I'm a senior associate at Open Minds. And Javi Favela is the Vice President of Solutions for Behavioral Health at Nextgen Healthcare. And today we're going to talk to you about CCBHCs and all the things that people need to know about CCBHCs. And then we'll end up with some overview of functionality that Nextgen offers that will help people be successful as a CCBHC. A couple of housekeeping items. All attendees are on mute, but we would encourage you to put any of your questions or comments into the chat. We'll be looking at those as we go and trying to answer as many as possible. What we want to do today is really go into the background of CCBHCs. We'll keep that relatively short. We know that most of you already understand that, but we do want to talk about this overview of the way that CCBHCs are funded through SAMHSA and their relationship with the FQHCs that are funded and regulated by CMS, and kind of how CMS and SAMHSA are partnering, where they're the same, where they're different, because we all know that there's some similarity between the FQHC Prospective Payment System PPS model and the CCBHC model. And then we want to help you understand what are the kinds of things that CCBHCs do that are important in terms of achieving a financial sustainability. And then I already said we're going to go over how some of the functionality in Nextgen can really help your organization. So with that, we can go ahead and get started. The first component of this is, why is everybody talking about CCBHCs? What is going on in our healthcare environment that makes CCBHCs so important? And this is a slide from the Milliman Group. For those of you who don't work in the insurance environment, Milliman is a professional entity that has become kind of the Bible, if you will, for actuarial projections associated with healthcare. Milliman is where commercial health plans, Medicare health plans, Medicaid health plans get their information to determine the norming of the potential utilization, the actuarial analyses. And so when you just look at this kind of four groups, right? High cost group with behavioral health illness, high cost group without behavioral health illness, low cost group with behavioral health illness, and low cost group without behavioral health illness, you see that the addition of behavioral health illness adds a significant amount of money. So in the high cost group, meaning they have a lot of physical health issues and have a lot of spending associated with healthcare, the average total costs are $45,762. So that's the top 10% of overall spend. You can see where behavioral health is a portion of that, and a smallish portion of that. And then you can see the kind of average PH cost. So why CCBHCs? CCBHCs are critical because if you can address behavioral health illness, you can medical cost offset physical health spend. It's not associated necessarily, of course, it's all about wellness for the person, but this very high cost group, how do you impact their high cost services? And the answer is you help ameliorate the behavioral health symptoms that are keeping them from achieving optimal outcomes for their physical health illness. So this is why CCBHCs are so important. And even if you look at the low cost group with behavioral health, you can see that the average PH costs in the column 2944 are still significantly higher, almost double, than the cost of the group without BH, without behavioral health. So you see this relationship between behavioral health spending, physical health spending, behavioral health illness, and compliance with physical health wellness. So, you know, in a rare bipartisan move, last year, the Safer Communities Act increased the opportunities for states to opt into the Medicaid CCBHC demonstration program. They promised funding through 2030, and the act includes $40 million in funding for this current fiscal year for planning grants and technical assistance grants. And those grant periods have already opened. So we know that SAMHSA has already started to give out this money. The granting process is important. These currently are grants through SAMHSA, which either are going to the state as a pass-through as part of Medicaid, or are going direct to the programs for states that don't have the Medicaid CCBHC program opted into. We'll talk a little bit about that later. But these funds are in the federal budget until 2030, or until the funds are used up. So we can see that, you know, people started talking about CCBHC at the federal level in 2013. In 2018, there was an additional $2.2 billion associated for CCBHC. There were a number of states during this period that did entry-level grants. So they did some grants to determine whether or not they wanted to become a CCBHC state. The federal government didn't really impose a methodology, so some states opted more of their services into the program than could be paid for by the money that was allocated for the program. So some of those states are now CCBHC states and some are not. Regardless of whether your state is a CCBHC state or not, this new round of grant allows an individual organization to become a CCBHC. And in 2022, as we just talked about, there was additional money that was allocated for development, improvement, and advancement. There have been 156 awards so far to the tune of $312 million. And today there are over 500 CCBHCs in 46 states. And that compares to, I think, only about 50 or 60 as you know, in 2017 when this first started. So the growth has been quite astronomical, and focused exactly on what SAMHSA has said that they want these programs to achieve. So our current status of participation, and you can see the different graphics, the slash marks are working toward independent statewide implementation. There are states that were selected for the demonstration, and then states where clinics have received expansion grants already. But you can see how widespread this is. There are, I guess I said earlier, 500 plus CCBHC programs now across 46 states, Washington, D.C., and Puerto Rico. And this is just another way of looking at the significant growth associated with CCBHCs, less than 70 in 2017, growing to over 500 in 2022. So this is obviously a program that has legs. It's obviously a program that is continuing to get significant federal support, and many, many states that did not originally adopt are either adopting or they are supporting independent grantees within their state. As we talked about earlier, in terms of why CCBHCs are getting attention, we know that people who have serious mental illness and also chronic medical conditions have much earlier mortality, than people who don't have those things. We also know that there's a price people pay both physiologically and psychologically from care that goes up and down and is not well managed. There was a really interesting article about how people with schizophrenia actually are having, brain-related trauma associated with relapses. So we know that people who have a chronic illness and are not as stable as they can be have cost issues that are higher than just money, that take a cost on their life, their employment, their social lives, their housing stability, and obviously all their symptomatology. So there's been a real focus for moving this, I'm going to pay attention to your mental illness, or I'm going to pay attention to your substance use disorder, into this looking at whole person integrated care, including things like your social determinants of health, whether you have enough food, whether you live in a safe environment, whether you're appropriately housed, et cetera, et cetera. And we move into the financial sustainability piece, and let me pull Javi into this a bit, because this is where we think that the CCBHC model from a financial perspective is designed to assure that financially the programs that are going to take on this very high need population are able to be sustained.
Yeah, thank you, Sharon. Yeah, I think one of the things that we wanted to spend some time on is specifically CCBHC, but also talk about this intersection, excuse me, with federally qualified health centers. As community organizations expand into whole person care or integrated care services to their populations, some of it through partnerships, some of it doing it as their, as their own entity. They're really considering the benefits of integrating an FQ designation into their care model in addition to becoming a CCBHC. Mainly driven, some of this is driven around obviously better outcomes, better quality, but also financial sustainability models with the prospective payment models, and we'll talk about that in a minute. This is a way to potentially cover for services that are not otherwise covered. And the intersection between CCBHCs and FQHC, right, we're really talking about more robust population management around these high cost, high risk members, and providing integrated care for those people that need it most. Also, billing and financing, so increasing the flexibility and the ability to bill for primary care services and cover those services that are not otherwise covered. And then it also gives you a competitive edge for CCBHCs, taking advantage of HEDIS measures, as well as, credit around quality improvements. I think really important is around primary care access for patients who call CCBHC or the CMHC their clinical home. This has demonstrated decreased utilization for patients through continuity of care, safety net, a delivery system in health shortage areas, decreased costs to system and payers, and really decreased fragmented care across physical and behavioral health providers. So getting into some of the CCBHC requirements, wanted to spend a little bit of time talking about the scope of services. So the requirements for a CCBHC, these are the services broken into 5 key areas. And then we'll talk about, in an integrated model, screening, assessment, diagnosis, patient-centered treatment planning, obviously outpatient behavioral health, mental health services, emphasis around substance use disorder and crisis services.
And just one thing on the crisis services side is, as states are implementing 988 and the CCBHCs are required to have some kind of 24/7 mobile crisis, the CCBHCs are becoming enjoined into the state's commitments to decrease suicide and to make suicide intervention resources available in a timely fashion. So that's another need for and another opportunity for CCBHC providers.
No, I think that's an important point, Sharon. And they're also, in the latest round of proposed changes, there is heavy emphasis around methadone prescriptions, really focus on substance use disorder, and then obviously integration with some of the changes that have happened in the crisis system with the 988 and policy changes around crisis services. We have some information that we'll provide in today's webinar on those proposed changes. Those were due for comment January 20th, so that deadline has passed. But we'll cover it. And in the appendix, we've actually provided some pretty detailed information for everybody on this webinar who pulled down the slide decks on those proposed changes. These are additional requirements for a CCBHC, whether it's delivered by you as an organization as a designated CCBHC or a designated collaborating organization, DCO. So that includes peer support, psychiatric rehab, targeted case management, primary health screening and monitoring, and primary care services, and then services to armed forces and veteran services. So certification criteria comprises of a total of 114 requirements across 6 domains. These requirements include such items as staffing plans, competency assessments, evaluation of physical accessibility, controls concerning quality of care, provision of crisis mental health services, community-based mental health care for veterans, a provision for care with respect to particular cultural needs of the individual, including linguistically appropriate screening and care. In the proposed changes that I had mentioned earlier, there's some emphasis around cultural needs and linguistically appropriate services, as well as a continuous quality improvement plan and a great deal more that are really most organizations already have in place, but organizational authority, governance, and accreditation.
I wanted to add one thing on the linguistics issue. There are a number of places where CCBHCs are being approved that are specifically resettlement areas, and so there's a huge incentive for the CCBHCs to be able to provide services in whatever those native languages are. So if you're in an environment where you are a resettlement area and you have the ability to provide services in whatever the native language is of that particular group, that's a big bonus point from a CCBHC standpoint.
This next slide, I think, is a really important slide that a lot of times we don't spend enough time on. And really for CCBHCs and even as a CMHC, we have lots of state requirements, regulatory requirements, managed care organization requirements, but data collection and reporting is key, right? So technology, your business intelligence capabilities, and subject matter experts are really required to be able to report on the 31 required quality measures. And even to further kind of complicate these things, if you're an organization thinking about the intersection between FQHC and CCBHC that we talked about, in addition to the 31 CCBHC reporting requirements, you have the complexities of UDS reporting as an FQHC. And depending on your state, additional reporting requirements as a CMHC and health and human service provider. So we can't stress how important it is that your systems are integrated, that you have sophisticated business intelligence capabilities to really be able to meet the reporting requirements. Many of the organizations that I work with that are CCBHCs and or FQHCs, this tends to be an area that most organizations struggle with. In addition to data collection requirements, there are also external data source requirements. And these are found in different external sources. You have regulatory requirements, things like that everybody probably in this webinar understand, right? State licensure policies, rethinking organizational org charts, the right staffing that's needed to meet the program requirements that are set forth by CCBHC, operational protocols, program description, staffing, training records, as well as various other requirements around quality management, patient engagement, client surveys, cost reporting, and then sliding fee schedules, as well as other outside external data sources. So when CCBHC is working in a managed care environment, a CCBHC must, to be reimbursed for services as designated by the state, be using a value-based payment methodology that's agreed upon by the MCO and the center. Continue monitoring and management of all potential preventable event measures, adjust prior authorization requirements required for services, the engagement of, especially with talking about the pilot sites, around care coordination, quality measurement discussions, and really focus on the development of that value-based payment structure to be demonstrated over that 2-year period. And then obviously complying with the requirements outlined in the CCBHC operational protocols.
And let me just jump in here before we get into the next slide, which is more associated with the specific types of payments. Just a teeny bit about Medicaid and Medicaid state plans and CCBHC states versus non-CCBHC states. So the way Medicaid works, for everyone's reminder of it for everyone, is that some of the money is federal and there's a state match. So depending on the category of aid and the reason that somebody got Medicaid, the federal dollars can be much higher or significantly lower. As an example, for states that went for Medicaid expansion, it was a 90% federal to 10% state match to bring those people into Medicaid. If Medicaid has mandatory managed care, then a grantee, a CCBHC grantee in that state, will get their money through CMS funding, the Medicaid program to the managed care companies, to the state, to go to the managed care companies, and the managed care companies then will pay that back in the form of a specific rate that they pay the CCBHCs. In programs without mandatory Medicaid managed care, the money can still come through the state, but can go either directly to the CCBHC or to the CCBHC through the state's Medicaid program. Regardless of how the CCBHC is getting paid, one of the most operationally critical components of a CCBHC technology infrastructure is that revenue cycle management, that being able to understand all the services that got completed and what you expect to receive based on your CCBHC flavor of payment. So I just wanted to set that as like a floor and then let Javi go on and talk about the different types of PPS models.
Yeah, and to Sharon's point, and we'll dive into the different PPS options here, but revenue cycle management and billing capabilities tends to be in the groups that I've worked with. This is typically where, in addition to reporting, where organizations struggle. We have some organizations, and quite a bit, that have both an FQHC and CCBHC designation. They also are grant funded. They have traditional fee-for-service models. They have commercial lines of business, and really making sure that you have not just the right integrated systems, but also making sure that you have highly qualified staff, which is really key to success here. When we look at the two prospective payment system models, so PPS option 1, this is a daily rate. This is like an FQHC prospective payment. It provides reimbursement on a daily basis. It's cost basis. Cost and visit data from the demonstration planning phase will typically be updated by the MEI or the Medicare Economic Index. The way this is calculated is the total allowable CCBHC cost divided by the total annual number of CCBHC daily visits, and this becomes the uniform amount per day. But note in this model, this is regardless of acuity level and intensity level of services or the individual needs, right? It's set based on that calculation. Under this specific model, the state has the option to elect a quality bonus payment, so it's not required. In the PPS option 2, this is a cost basis per clinic, but it's done on a monthly basis, so it's a monthly rate. The state has a little bit more flexibility, which also adds a lot of complexities. Outlier payments, so the prospective payment system or payment for the CCBH costs in excess of a threshold payment is also defined by the state. And under this model, the actual quality bonus payment is required by the state. Sharon, I don't know if you want to add to that, but this is the kind of two fundamental PPS options that you will see in the CCBHC model.
Yeah, no, I thank you, Javi. That was great, and I think that this is one of those areas where if you are thinking about either going after a CCBHC grant yourself or partnering with someone so that you have the full suite of services, and just FYI, 100% of those required services that Javi talked about earlier must be part of the CCBHC program. You can either provide them directly yourself, or you can contract with an entity to provide those services. But as that contractor, you are still responsible for all of the quality components associated with those services. So that full scope of 9. And often people will partner on the physical health side. They've been a community mental health center, they have an ACT team, they have a mobile team. And so they say, okay, I'm going to partner with a primary care organization. These PPS models and the entire revenue cycle management component of CCBHC requires that you're really paying attention to your partners and your partner's ability to report to you so that your cost reporting and all of your revenue cycle management can be done really pristinely, because many of the CCBHC programs misestimate in their first year or so what the volume is going to be, and so they end up not having as much revenue as they thought they were going to have, which means that their grant money may be used not just for building but also for the program. And obviously, as with any SAMHSA grant, the goal is that the program is self-supporting before the grant period ends. So that paying attention to not just your revenue cycle management, but your partner's revenue cycle management capabilities becomes really, the difference between success and failure.
So in regards to quality measures for bonus payments, so these are the required and eligible quality measures for those bonus payments. Required measures are really focused around follow-up after hospitalization, medication adherence, emphasis around patient engagement for people with substance use disorders, and an emphasis around suicide risk assessments on those high-risk patients. Eligible measures, states may propose additional QBP measures with CMS approval. This is follow-up care for children, screening for clinical depression, antidepressant medication management, focus around readmission rates, depression remission at 12 months for adults. So these are the required and eligible potential quality bonus payments, quality measure for bonus payments that we had talked about earlier in the previous slide.
So this is another example of why your lifeblood for your CCBHC is associated with service-related data. Revenue cycle management, obviously a huge component, but keeping track of things like follow-up after hospitalization, adherence to antipsychotics, suicide risk assessments in adults with major depression. These are all things that are dependent upon a simple, from a workflow standpoint, a simple point of service data capture capability. So how do I know that every person who has a diagnosis of major depression has also had a suicide risk assessment? And the answer cannot be, I physically go into all the charts and I check the notes to see if there's a suicide risk assessment. Being able to comply with these required measures and then the eligible measures for potential either bonus points or scoring is a data management issue, a data workflow issue. And it's one of the reasons why I think the most recent kind of modifications to the electronic health records in this particular market space are really all around ease of data capture and then ease of data analytics. So it's one thing to capture that the suicide risk assessment was completed. It's another thing to be able to simply pull that out of your data system for the purposes of reporting.
Wanted to talk a little bit about CCBHCs in the area of value-based care. We did see a question ahead of the webinars. People were registered. There was some emphasis around value-based care. The models are similar to payment models evolving in the healthcare field, like case rates for unit of service, which looks like a PPS option 1, or population payment for services over a time, to a specific group, which looks like PPS option 2. If you remember in our population health, for those of you that attended our VBC webinar that Sharon and I talked about, a lot of the VBC payments that you see, if you've gotten into a VBC contract, look very similar to these prospective payment models, especially with the potential, option for a bonus payment. The difference between the models evolving in the field and the CCBHC model is the use of a cost as a basis for payment, right? Getting back to financial sustainability. I think it's really important that you have the right, as Sharon mentioned, the right technology, the right subject matter expertise to be able to do the cost accounting, to make sure that you have actuarially sound, projections, including cost per unit and per case. You need the ability to be able to manage an episodic rate of service, in addition to the administrative and clinical requirements. And so the electronic health record and business intelligence, as well as the integration of all your other platforms and health information exchange functionality is really key. You also, especially in the environment that we're in around labor shortages, really help optimizing the workflow, clinical decision support tools to help you be able to provide access to your consumers, to be able to meet the patient where they are and to activate and engage them. And then have systematic quantification of those quality measures. As Sharon mentioned, we're doing it, it's in our workflow, it's in the clinical workflow, but how do you get it out in a meaningful way to meet those reporting requirements? The investments in infrastructure for CCBHC as the same as those for similar to what we see when value-based payment models are being put into place around population health, data analytics, very similar in terms of what we see between a CCBHC and your more traditional VBC payment. So these are the draft, and we're just going to highlight the significant CCBHC changes that were proposed. As we mentioned earlier, since the initial criteria was published for CCBHC, SAMHSA has since then developed guidance around components of a comprehensive crisis system in its national guidelines for the behavioral health crisis care. There's actually a best practice toolkit. In addition, and Sharon mentioned this, the National 988 Suicide and Crisis Lifeline were established. States have been working to develop their crisis systems. And so crisis, there was some emphasis in the changes around crisis care and requirements around the criteria that have been drafted to amend to align to those changes in national guidelines, the implementation of the 988, while recognizing that there's still differences in state definitions and the varying availability of actual crisis services. Another consideration, there was some emphasis in the proposed changes around trauma-informed approaches must be applied to crisis care services. When you look through a little bit more in detail, there was requirements that are being proposed that a CCBHC have a care coordination partnership with a 988 suicide and crisis lifeline call center serving the area in which the CCBHC is located. They've made proposed changes around updating the required response time of the mobile crisis team because its response times are now more clearly defined in section 4C. And then there was more detail around crisis stabilization and established a minimum threshold for those crisis stabilization services. And there was also some revisions to address the risk of drug and alcohol-related overdose and intervention support following a non-fatal overdose.
So one of the reasons that there is this focus on crisis care models is associated with bad situations that have had when someone was experiencing a psychotic episode and law enforcement was called and did not know how to de-escalate the situation, which resulted in injury and in one very tragic case, death of the person who was having the psychotic episode. We know that people who are having psychotic episodes may seem aggressive, may not be easy to restrain. And we also know that trauma-informed crisis services are very, very successful at de-escalating those kinds of situations and having the person end up safely in an inpatient unit rather than end up in jail. And so the federal government has now decided to kind of make that part of the requirements and recommendations associated with the onset of our 988 suicide prevention hotline programs.
There's also been some significant emphasis in response to the opioid epidemic in these draft proposed changes. Specifically, there was some clarification that the requirement of a CCBHC, they must have the capacity to be able to prescribe FDA-approved medications used to treat opioid and alcohol use disorders. However, it makes an exception for methadone. If the CCBHC does not have the ability to prescribe methadone directly, it must provide a referral to an opiate treatment program with care coordination to ensure that access to methadone services are available as they are in scope of these services. There also put some requirements around to consult with or have on staff addiction medicine specialists or a physician on staff unless the medical director has experience with substance use disorders themselves. And then lastly, recognizing the need for the ability of methadone. As I mentioned earlier, if the CCBHC does not have the ability to prescribe methadone directly, it must be able to coordinate care. And then we wanted to just, here at Nextgen, just talk a little bit about Nextgen. We obviously focus on whole person care. We've got well over 400 behavioral health and integrated care organizations, many of which are CCBHCs and FQHCs. It's important to us as a company that we're offering one single system, a full comprehensive behavioral health solution, a full comprehensive FQHC, as well as 26 plus specialties, and the surround solutions that are really key to being successful. So population health care management, patient engagement, health information exchange, interoperability. But the one thing that we don't talk about, which we do see CCBHCs and federally qualified health centers moving into, is the ability to be able to provide oral or dental health, right? So our solutions are very much focused on one single system across the full continuum of care. And then most importantly, that capability around CCBHC and UDS reporting, and a team of subject matter experts. We've worked with a lot of organizations in an integrated model who have a CCBHC designation and or both an FQHC designation. So the importance of technology, as Sharon and I have mentioned for CCBHC, integrated solution is really key, but the capability to be able to report with autonomy, the efficiencies created with one single system to increase efficiency and outreach, better care coordination around interoperability, one single system across the full continuum of care, improve and maximize financial performance by having robust revenue cycle management capabilities. As you know, we talked about earlier, revenue cycle management is becoming even more complex than it already has been as a CCBHC and CMHC, and then really making sure that we're saving valuable time, and then around population health, being able to identify high risk, high cost clients and have ability to impact. We have solutions and capabilities aligned with the integrated CCBHC and FQHC model. I'm not going to go through all these. I think we covered them earlier. A comprehensive, making sure that we support comprehensive and complex behavioral health services, so all levels of care. We are an ASAM distributor reseller for ASAM, which is the golden standard when it comes to level of care assessment for substance use disorders, pretty much covering the full gamut, as well as even additional complexities to support Medicaid rehabilitation options. We have some states where, in addition to the complexities that you see around CCBHCs, FQHCs, our traditional fee-for-service models or subcapitated models, there's also some complexities for those states that are in an MRO environment. We also have, out of the box, we offer full and included in our install, we offer, even if you're not a CCBHC or you are, we offer our CCBHC reporting capabilities to all of our customers. These reports are available in our latest release, and we support all of the required reporting requirements for CCBHCs. And this is going to be available to everybody, but we are offering everybody who has joined the webinar, who's looking at systems. We have a CCBHC innovation package, really focused on all the things that I talked about. Because this deck will be available, you're able to scan to learn more. It'll take you right to our website and show you our capabilities and offering for this package. And lastly, everybody that's joined is familiar with Whole Person Care Headquarters. I did want to announce that I think we have this slide up every time. We now have the competitor financial analysis tool. The next one coming up is the financial strength expansion compatibility calculator. You can visit us at hpchq.com to access those tools, as well as our these webinars, best practices, articles, tools, really focus around whole person and integrated care, behavioral health organizations, and human service organizations.
And there have been a number of questions that have come in specifically associated about where can we find the tools and where will this webinar be. So if you go to wpchq.com, you will see links to past events, and everything will be, everything about this one will be there. Javi, is this a good time to go into some of those questions?
Yes.
So we did have a series of questions that came in prior to the webinar. Hopefully many of those have been answered, but I'll go through them very quickly. One person asked a series of questions about where would CCBHC find people who needed the service, how are the services funded, how to qualify and how to maintain qualification, and what staff support is needed. So that was one question. And the answer is that when somebody is applying to become a CCBHC, they actually have to complete a grant proposal. The grant structure is available on SAMHSA's website, and it answers all the questions about what kinds of work you need to do ahead of time to assure that your answers are responsive to SAMHSA. So one piece of it is why in your geographic location do you feel a CCBHC is going to get enough patients? And so all of those questions are answered by looking at the grant proposal itself rather. We answered a CCBHC value-based program. This is an interesting question. What are the common growing pains that newly designated CCBHCs encounter during their first 2 years? And I'm happy to kick that off.
Yeah, why don't you kick it off and I can talk about my customers.
Great. I think that the number one is that the patient-client activity is not high enough to fully fund the program once the grant monies are used up. That there's either a miscalculation in terms of projection of need, or more likely there's that constant conflict we see in behavioral health between direct services that are billable and indirect services that are not billable. And that's where your charting and your revenue cycle management becomes so mission critical. Because CCBHC has an expanded definition of service, many things that weren't traditionally billable under regular outpatient could be billable under CCBHC. Finding those billing opportunities, I think, is a challenge that many of the new CCBHCs or a CCBHC in its first 2 years of life, I think, has experienced. Do you want to add to that, Anna?
Those are spot on, Sharon. Those are probably the two biggest things that we see. The other is a lot of times lack of integration of technology, bifurcation of systems, right? So that reporting on the quality measures tends to be, in addition to revenue cycle management, typically is an issue, as well as ensuring that if you're using a partner, right, a designated collaborative organization to provide the primary care services, sometimes that data is not getting back for you to do the proper care coordination as well as the reporting that's required. So I think those three are probably the biggest issues that organizations have. And then, everybody has the labor workforce issue. As you're trying to grow programs and services, you have funding to support that growth. But certainly, and this is true across the entire healthcare system, obviously, labor shortages are still an issue.
Yeah. And we have another question that I think piggybacks on that one, which was, what tools are available for DCOs to report data to CCBHCs? And to me, the answer gets back to kind of where Javi started, which is interoperability is the key, right? Yeah. You have to be able to accept data from disparate systems. You have to be able to send data from disparate systems. You have to be able to push data out to your clinicians so that they can see the things that have happened while they were offline, while that client was in a different facility. You have to make the information available so that you can be maximally efficient and effective. So when you do that DCO relationship, you have to put in that contract what your expectation is for them and their systems. And they need to be able to send you data and not just send you paper or not just send you Excel spreadsheets, because if they do that, you're going to be data entering stuff into your system to allow you to report. And that is time consuming and it's inefficient and it lends itself to data entry errors. So you really want to pay attention to interoperability as a general principle, which is if I send you a file that is structured, that has table names, can you import that file into your data systems, either at the back end in a reporting capability or on the front end to actually be integrated into your clinical record? I can't say enough about how data management is important in being successful as a DCO or as a CCBHC that has DCOs.
And the governance around it also super.
And the governance, yep. Yeah. And then the last question we have is a long one. We have a behavioral health IPA in New York State. Many of our attributed members are involved with the CCBHC. We have value-based contracts with a few MCOs, but because the CCBHCs bill the state directly for services, the MCOs don't necessarily get all the data for those patients. And so we know that we're hitting the HEDIS metrics, but since the CCBHC data set doesn't populate the MCO data set, they may not have gotten credit for those in HEDIS measures. Is this only happening in New York State? Or have you heard of data issues and VBP opportunities for others in CCBHC? And the answer to that question is no, it's not just a problem in New York State.
It's everywhere.
It's everywhere. So it's kind of where I started with if the money comes through your Medicaid state plan and it goes through a Medicaid managed care environment and the Medicaid managed care environment is paying the CCBHC, then they're getting those encounter records back. But if the money's going direct to the CCBHC through the state, the MCOs could potentially get cut out of it. And that issue of which patients and their outcomes are attributed to which reporting data set is one that I think is becoming more and more of a national conversation. And as an example, through Open Minds, I was working with someone in another state. We were working on a process directly with an insurance company to take some risk for a specific population to keep them out of the hospital. And the insurance company said, these people are already in a value-based arrangement with their primary care doctors. So we can't do another value-based payment arrangement with you because how will we know who did the service and therefore who should get the bonus? And so I think that really is probably one of the biggest issues that we're going to see as these programs and as the kind of meeting together of FQHCs and CCBHCs together happen, as primary care medical homes start taking on more behavioral health risk. I think we're going to see more and more the need for some guidance from states and from the feds about what to do with this reporting that could be attributed to more than one clinical entity.
Yeah, and we see the same thing, right, in value-based care arrangement to your example, Sharon, where, right, you have attribution issues, like who is the designated entity, because that's where the VBC payment goes to. So we see that challenge even outside of, CCBHCs, but it is everywhere. In addition to a lot of, a lot of manual work that really has to be automated. That plumbing has to be around interoperability really built in, but we are seeing outside of New York for sure.
Yeah, it looks like we have one last question and one last comment, and then I think we're out of time. The person who asked the question about New York State said they really need to carve out BH patients or have a downstream agreement with the primary care IPAs. Couldn't agree more. They have to figure it out. As the feds and the states are moving towards a whole person care model, as we are actually being able to use CMS type money for things like social determinants of health, it's going to become more and more convoluted. So we have to figure it out. And one thing that all of you can do is make your reporting methodology excruciatingly clear when you go into those value-based arrangements. And by that, I mean, who's going to have the data? How are we going to get the data? Who's going to get credit for the data? What do you do when there's confusions in the data? And make all those things really super clear.
Yeah. How do you resolve that? Yeah.
Yeah.
I think that was in our last session. Yeah.
Yeah, no, I mean, I think that's probably one of the most important things we could ever say to anybody, isn't it, Javi? That you should really understand your value-based contracting structures before you sign anything. I think with that, we are almost out of time. So thank you all so much for joining us. Again, don't forget to visit wholepersoncareheadquarters.com. Thanks again to Nextgen Healthcare. Please take a look at the materials that you're going to get through a link that we'll be sending to you. Please let us know what you think of this webinar and any ideas you have for other webinars you might be interested in. And again, thank you all so much for joining us, and thanks to Nextgen for making this possible.
Yes, thank you, everyone.